Welcome to Heart Failure Minutes. I'm Dr. Milica Vukićević. Today we turn our attention to a condition that has moved from the shadows into the center of cardiovascular medicine, cardiac amyloidosis. Once considered rare and often diagnosed too late, it is now increasingly recognized as a treatable and clinically meaningful contributor to heart failure, particularly in patients with preserved ejection fractions. To help us navigate this evolving landscape, I'm today joined by Dr. Sarah Cuddy, Director of the Cardiac Amyloidosis Program at Mass General Brigham, someone at the forefront of redefining how we identify and manage this disease. Dr. Cuddy, cardiac amyloidosis has long been underdiagnosed, actually. What are the key clinical signals that should prompt suspicion today, and how has the diagnostic pathway evolved?
Yeah, well, thank you very much for the invitation to talk on this topic today. I love spreading awareness of ATTR cardiac amyloidosis and actually all forms of cardiac amyloidosis. Focusing really on ATTR, because that's where we've seen kind of the most advances therapeutically and diagnostically in the last decade or nearly 2 decades now. When we think back on kind of clinical alarms, generally this has traditionally been a disease of kind of older men when we think of the wild type form. There is also variant forms, and in North America one of the commonest variants is called V142I, previously known as V122I, which predominantly affects Black Americans. Again, older in age. So when we see those older patients where they were on antihypertensives for years and now their blood pressure's dropping, they're no longer tolerating antihypertensives or beta blockers, that's definitely a red flag. We know that the amyloid can involve the tendons and ligaments years prior to meaningful cardiac involvement. So again, if they have an extensive history of orthopedic issues, especially bilateral carpal tunnel, spinal stenosis, we talk a lot about biceps tendon rupture. What's interesting is commonly in my clinic, patients are not aware they've ruptured a bicep. It's really only when you look an exam and point it out to them that they say, oh yeah, I noticed it kind of was bulging more. So that's kind of something that needs to be looked at on exam. So they're kind of some of those red flags that you can think of in older patients with heart failure or even difficult to control atrial fibrillation. On echo, there's a number of clues. I really think we're at the point where if patients have increased wall thickness, we really need to think of an etiology for this. Research we did showed that if the posterior wall is greater than 14 millimeters in an older person, there's a pretty high likelihood that this could be ATTR cardiac amyloidosis. So that really needs to be further investigated. If you're lucky enough to have strain as part of your kind of workflow in your echo lab, apical sparing again can be a real red flag on global longitudinal strain.
As you already mentioned, amyloidosis is not a single disease. Can you help us understand the key biological differences between AL and ATTR and why that distinction matters clinically?
Yeah, so there are several proteins that when they misfold, they can form amyloid that causes systemic disease. We refer to these as the precursor protein. So in the diagnostic workup, that's one of the kind of essential things. What is the precursor protein here driving the amyloid production? In cardiac amyloidosis, the vast majority of cases are either TTR, wild type or hereditary, or AL. And then rarely, even in our specialist center, we see kind of other forms of amyloid affecting the heart. AL amyloidosis is light chain amyloidosis. So it's a pathological light chain process, usually related to a plasma cell dyscrasia. So something's happening at the level of the bone marrow with abnormal production of either kappa or lambda light chains. What we know is that this can often be a much more toxic process and much more multi-organ process than TTR amyloidosis. When we talk about TTR, we think of tendons and ligaments, as I mentioned, the heart, and also in hereditary forms, we can see polyneuropathy, autonomic or peripheral. AL amyloidosis can really affect nearly every organ system save the central nervous system. And it's a very heterogeneous presentation. Some patients will present just with heart, just with kidney, or with both. And really there's an urgency there, again, kind of related to this toxicity of the light chains. These patients really still have, unfortunately, kind of low survival when untreated if they present with heart failure. So you want to get the diagnosis made quickly and treatment initiated quickly.
The therapeutic landscape has changed dramatically. Where are we today, and what should clinicians be thinking about as we move forward?
Yeah, this is really, I think, where the excitement has been in the last decade, especially in the TTR space, and what's kind of driven our interest in making the diagnosis. And as we mentioned, now we can make the diagnosis non-invasively in ATTR cardiomyopathy in the absence of a pathological light chain. So if you've done the workup where you check for serum-free light chains, serum and protein immunofixation, and that all looks normal, you can do a nuclear scintigraphy study with the bone avid radiotracer, PYP, HMDP, or DPD, depending on local availability, to make this diagnosis, and then initiate therapies. Again, therapies go back to this principle, addressing the precursor protein. So in TTR, the majority of this is made by the liver. So we're trying to either stabilize this protein and prevent it from breaking down and forming amyloid with stabilizers. Tafamidis has been on the market since 2019, FDA approved in the US. Acoramidis has been approved since 2024, late 2024. And then we have stabilizers also, or silencers, also in ATTR cardiomyopathy. They were initially approved for the hereditary ATTR with polyneuropathy back in 2019, but the first to get approved in ATTR cardiomyopathy was vutrisiran, which got approved in 2025. So this is a small interfering RNA molecule that acts directly on the liver to knock down the production of TTR. We have a lot more molecules in clinical trial, another silencer, eplontersen, that should read out later this year. And hopefully this will answer one of the questions on everybody's lips. Is combination therapy with silencer and stabilizer better than kind of one alone? We don't have an answer to that at the moment, but I think everyone's excited to see if this trial will give us those answers, because it will be the biggest trial in ATTR cardiomyopathy with 1,400 patients and a lot on baseline tafamidis. The holy grail is amyloid removal, ongoing trials in the TTR space. But when we talk about therapies, we always talk about TTR, but there's actually been super improvements made in AL amyloidosis. So when that diagnosis is made quickly and we can initiate patients on therapy quickly, we can see really good outcomes for these patients. So again, we're looking for this kind of rapid reduction in the light chain levels. So standard of care is now daratumumab, or daratumumab, cyclophosphamide, Velcade, or bortezomib, and dexamethasone. So this combination has been proven out in phase 3 clinical trial. And once the patients we normalize their light chains, we really see very good outcomes for these patients. Unfortunately, for those patients who don't normalize their light chains rapidly, we have to think about second line therapies. We adopt a lot of these from treatment of multiple myeloma, and luckily in our centre we've seen some really exciting results with BiTE therapy, so bispecific T-cell enhancers targeting the BCMA receptor. So I think this is also an area of incredible development and growth and hope for our patients.
Thank you very much. Cardiac amyloidosis definitely reminds us that not all heart failure is created equal. Recognition demands vigilance, diagnosis requires precision, and treatment hinges on understanding the underlying biology. As the field advances, what was once a diagnosis of exclusion is now a call to action. One that offers a real opportunity to change the trajectory of disease. I'm Dr. Milica Vukićević, this is Heart Failure Minutes, and I'm signing off for now. Until next time.